We welcome you all once again to this week series on precision oncology. And we have India's topmost medical oncologist from Chennai area, Apollo Medical Hospitals. He is the Director of Medical Oncology, Dr. T. Raja. Very, very happy to have you here today, sir. And we will be very glad to listen to you on your lecture today on RET gene mutations and its role in targeted therapy. So to brief you about Dr. T. Raja, Dr. T. Raja is a senior consultant medical oncologist and director of medical oncology from Apollo Hospitals, and he comes with more than 20 years of experience in treating cancer patients. He has been part of several international randomized clinical trials and has played a very key role in bringing many drugs to India in terms of precision, improving the precision medicine and its treatment in India today. And he has won the gold medal at Gujarat University for his DM in medical oncology. And he has published he has published in several international and national journals some of his key achievements in clinical oncology. Without much ado, I would like to welcome you, sir. Kindly start your presentation.
Thank you, Dr. Vidya, for your kind introduction. And it was very generous, but I'm happy to be with you all. And I think my slides are visible and my voice is audible.
Yes, yes.
Thank you. And, happy to connect with all of you over the web. And I'm also pleased to talk on this topic because these are very exciting times. And we know that precision oncology and the targeted therapy is the real buzzword now for the past several years. And RET tumor and RET changes or RET alterations are the real hot news, and the new kid in the block is RET. So I'm happy to talk about RET in solid cancers with you all. And so RET was actually detected as an accident when Dr. Takahashi was trying to look at, he was doing some transfection from one mouse to another. At that time, he just stumbled on this as a proto-oncogene. And that was the first, description of RET. That was way back in 1985. Then it was quickly recognized that it is a growth factor, growth factor receptor of glial cell, and glial cell line derived, GDNF family, and it also finally encodes the receptor tyrosine kinase. So then the RET gene was located in the chromosome 10, and it contained 21 exons. We are going to look at this. These are the 21 exons in the RET gene. And it was also observed that the RET in particular is expressed in neural tissue, brain, autonomic nervous system, so on and so forth. And very quickly, it was realized that this was the alteration that was associated with Hirschsprung's disease. And while gain of function was then soon to be associated with malignancies, and particularly medullary thyroid carcinoma came to the fore, and then multiple endocrine neoplasia 2A, 2B was also found to be associated. So that's the history of RET, detected in 1985, and then thought as a growth factor, and located in chromosome 10, then quickly was found to be associated with solid tumors, particularly started off with good knowledge on good association with carcinoma, thyroid carcinoma, medullary thyroid carcinoma. Subsequently, you will see that it is associated with various other solid tumors, then multiple endocrine neoplasia. That's how the RET story began. And so this is the RET gene and protein in a little bit of a zoomed situation. And this is chromosome 10, and you can see the 20 exons that kind of code the RET protein. And this is the RET protein. That is, this is the cell membrane and this is the this is the justa membrane sites, and this is the above membrane sites. We'll look into this in detail. All these are important because that will help us to understand how RET functions, and what are the common alterations in RET, and how therapy has come into play in this one. Now, the RET alterations, the common ones are RET mutations, that is 2%, and RET fusions 0.36%, and RET loss 0.3%, and RET codon missense. So RET can be altered in different ways, and this is seen now in a number of solid tumors. So that is, and each of these, if you look at this closely, each of these are now associated with specific changes in the given exons. We are going to zoom this closer and look at it again. So these are the these are the chromosome 10. If you look at it, how fascinating it is. In this site, the RET oncogene is located, and if you expand that, you get the 20 exons. And then if you see the functionalities of that, this is the RET protein, and this again has got in the structure, this is the membrane, on the membrane, this is the transmembrane domain, this is the juxta or below the membrane trans-tyrosine kinase domain, and these are above the membrane, that is cadherin like domain, and cysteine rich domains are above the cell membrane. So this is how the RET protein is structurally arranged, and it is found to be associated, the alterations are found to be associated in a significant number of solid tumors. So it's actually a pan cancer. It could be anywhere from lung adenocarcinomas to colon, thyroid, and cutaneous melanomas in that order. And then you can see it as down below as breast cancer, as anaplastic astrocytomas, so on and so forth. There are many solid tumors. That's the message we want to say. And this is how the RET pathway works. And we have spoken about the RET protein. This is exactly the juxta membrane, membrane domain, and below the membrane tyrosine kinase receptor domain, and this is the above cadherin like domain and cysteine rich domain. So we talked about that. But then downstream, once it is activated by all these growth factors, you will see a downstream amplification of PI3K, AKT, mTOR pathway, and then the RAS-RAF, MAP kinase, and then we also see the MAP3Ks, MAP2Ks, and so on. So it then activates multiple pathways, and which drives down to angiogenesis, autophagy, so on and so forth at the level of the cell cycle. So this is the genetic oncology publication on how the RET pathway works. And it is also already understood that the RET is important in the tumor microenvironment complex. So that's this the GFL RET signaling is modulating the relationship between the tumor and its surrounding. So this is the nerve environment, and this is the pro-inflammatory environment, and RET somehow seems to have an influence on these interaction of the tumor cell with its environment. So that is one specialty about the RET. So how do we then detect these RET genetic alteration? There are multiple methods, right from RT-PCR to IHCs to NGS, but it is now universally agreed that NGS broad panel is probably the best way to detect the RET alterations, because I have already mentioned that the RET alterations themselves are not homogeneous. There can be multiple alterations. So then came the interest in how do we treat the RET altered malignancies, particularly the RET altered medullary thyroid carcinomas. Vandetanib was the first drug that was approved for RET altered medullary thyroid carcinoma. This was in 2011. After that, nothing much happened in the RET domain for several years until 2015. Then started the work on selpercatinib and another important drug. We're going to talk about this, but selpercatinib was first known as Loxo 292, and this was first selective RET inhibitor, and this the Liverto 001 trial for RET altered cancers, and because it was a highly selective, kinome selectivity for the RET. This is the Luxo 292, and this is the xenograph model and the brain model. And the 001 trial included multiple tumor types: non-small cell lung cancer, thyroid cancer, pancreatic cancer, so on and so forth. It also included the multiple changes in the RET, and these are the most important RET mutations and RET fusion partners. We said that RET can be altered in many ways. The most important thing is mutation or fusion. In the fusion, again, it's very important to know about the KIF 5E, and this is CCDC6 and NCO 0404. These are 0A. These are the most common changes in the RET fusion as partners, and there are several other partners. It's important to know that it's not a single change, but there are a plethora of changes, be it mutation and fusion. There are some other changes with the RET, also missense changes and so on and so forth. But I mean, that's why a broad-based NGS is probably the best way to detect, all these changes in the RET. But otherwise, we're going to miss quite a bit of these changes by RT-PCR or very narrow band tests. And this 001 trial was actually a phase 1 trial, which was actually a dose escalation design from 20 milligram QD to it escalated up to 240 milligram BD. And these are the multiple cancers that were treated with Luxo 292. Now, what was immediately noted is the response rate. The response rates were suddenly found to be very impressive, and if you talk to the investigators, they will say that within 2 weeks, 3 weeks, the patients completely turn around. And anecdotally, and the legend is that very sick patients who were literally wheeled in, and when they were enrolled in these trials, for want of options, and they were found to be much better in 2 weeks, 3 weeks, so much so that they went back to work and started moving around and flying, and all that happened in 3 to 4 weeks time. That's what the investigators would tell you. Such an impressive and quick response is what they allude to. And if you see, the overall response rate is 77% for all cancers and non-small cell lung cancers, and then RET mutant medullary thyroid cancers, and the response rate is as high as 45%. And you can see that when there is no known RET alteration, there is zero response. So you can see that the response is very specific and very high overall response and a very quick response rate. So this is the hallmark of our RET inhibitors. And this is the overall response rate. Once again, mind you, all these patients are already pre-treated, and they were all enrolled because there were no other options to treat them. And in patients who were treatment naive, you will see a response rate of, 85%. That's very, very impressive in patients where there are no other options. Treatment naive in the sense they were not treated with prior platinum therapies, particularly in lung cancer. And when there is a prior platinum exposure, you still see an overall response rate of 68%. So the moral of the story is that the Liberto 001 would establish this particular high response rate across the board, Luxo 292. And this Luxo 292 eventually comes to be known as selpercatinib. And this is the recent publication in New England Journal, Efficacy of selpercatinib in RET altered thyroid cancers. In the entire population, when we look at the thyroid alone, that's the article that is published here, and this appeared last year in the New England Journal of Medicine. And you see that this is RET mutant medullary thyroid cancer, which were previously treated, RET mutant medullary thyroid cancer, which were not previously treated, and this one is any RET positive, RET fusion positive thyroid cancer, which were previously treated. But if you see what's happening here, all of them have an objective response rate of, whether it's independent review or investigator assessment, you have a response rate upward of 60 to 70 across the board. So that's very, very impressive. And you can also see that there are some complete responses here. And if you look at the progression-free survival, you see that the progression-free survival is, in some of these subset is reaching to 23, 27 months. Patients in tumors where the prior options were very less, and the prior response rates were not good, and the median, progression-free survivals were not known to be there. But here is why you see such a good PFS and impact. If you look at this waterfall plot for response, this is RET mutant medullary thyroid cancer, which were previously treated with vandatinib or cabozantinib. These were the prior known drugs that were used in treatment of RET altered patients. In these patients, wherever there were prior exposure, and when you put them on selpercatinib, what you see is such an impressive waterfall plot. Almost all patients, except this small subset of patients, almost all patients show response, and most of them show a very deep response. Most of them show a very deep response, and you can also see such good complete responses in a good number of patients. And if you look at patients who were not previously treated with vandatinib or cabozantinib, you see the waterfall plot curves become even more impressive. There is absolutely no positive skyscrapers. Everyone is below the line, and everyone is waterfalling down here. Such good response. Most of them are deep responses, below about 20%, 25%. You see such deep response in a large number of patients. And this is fusion, RET fusion positive thyroid cancer. Once again, when you put them on selpercatinib, you still see that, you see very impressive waterfall plots showing the response rates and a very good complete CR in some of these patients. So be it mutant, be it fusion, selpercatinib treated or untreated patients shows impressive response rate and waterfall plot. And you also see such a good duration of response. You can see that the median of the duration of response is still not reached, and it is already crossed more than 18 months. And the progression-free survival is already crossing 24 months. So these are the Kaplan-Meier plots for the PFS. And we need to know the adverse events. And it is said that the RET mutant treatment drugs, pralsetinib and selpercatinib, both are somehow well tolerated, much better toxicity profile. But we still need to know what are the toxicity profile. There is a bit of dry mouth, hypertension, diarrheas, and this is the toxicity profile. And fortunately, there are not much grade 4 and very less grade 3 toxicity, one would say. So the Libido 001 would conclude that this is a phase 1 and 2 trial which has shown durable efficacy with low-grade toxic effects in medullary thyroid cancers with or without prior therapy with vandatinib or cabozantinib. So that is the, based on this, selpercatinib is approved for thyroid cancers with RET gene mutations or fusions, and for lung cancers with RET gene mutations or fusion. This approval was in May 2020, FDA approval. And moving on to the next drug of interest, that is pralsetinib. Pralsetinib was also called as a blue drug. And pralsetinib, again, this was one of the earlier publications, 1 year ago. This is the Aero study, which is again a kind of a basket study. It's a multi-cohort, open-label phase 1 and 2 study. And RET fusion positive non-small cell lung cancer. Again, this is a multi-center, multi-cohort trial, and the early publication would show that it is well tolerated and a new promising once a daily oral option for RET fusion positive non-small cell lung cancer. And this publication appeared in the Annals of Oncology. But then, this is the efficacy of pralsetinib in the Aero trial. And again, you see that with pralsetinib, you see a response rate of 60% and 70% in patients who had no prior therapy. But the most important presentation of pralsetinib was presented in last year ASCO by Dr. Vivek Subbiah. And this is the clinical activity of RET inhibitor pliancetinib in patients with RET fusion solid tumors. All, it will include all solid tumors. And just as an introduction by Dr. Vivek Supaya, the medullary thyroid cancer RET mutations were seen in 50% of the medullary thyroid cancers, and germline as part of MEN syndrome in 100% of the patients. Then papillary thyroid cancer, 10 to 20%. And you also see these RET alterations in lung cancers to the tune of 2%, and breast, pancreas, and cholangio less than 1%. And ovarian epithelial carcinomas around 2%, and colorectal, wide variety of malignancies. So you can see that the RET alterations are an unmet need, a broad range of tumor types. And pralsetinib is once again a very specific, high selectivity for activating RET alteration with very low affinity for other kinases, as we had shown in the cartoon for selpercatinib. This also has got a very low affinity for other kinases and very high selectivity and very specific. 81-fold more selective for RET than than the other receptors like a VEGF-R2. So it's very highly selective and very highly specific. So this is the Aero study, which we already mentioned, showed that the RET fusion positive non-small cell lung cohort was already published, and this is the non-small cell lung cancer patients, 400 milligram OD. This is the response rate waterfall, 73% overall response rate. But then the other cohorts of the Aero study is the medullary thyroid cancer and other solid tumors. If you look at the medullary thyroid cancer, again, you see 74% overall response rate. Again, very deep waterfall plots for pralsetinib also. And these are the baseline characteristics, and particularly for thyroid cancers, you see that these patients were prior treated with radioactive iodine, lenvatinib, so on and so forth. And these are about the other solid tumors that have the RET fusion, and this is the range of malignancies: papillary thyroid cancer, and then you have pancreatic cancers, cholangio cancer, ovarian, and sometimes colon and thymus. So a range of malignancies, and this is the activity of pralsetinib in RET fusion positive thyroid cancer. You see an overall response rate in fusion positive thyroid cancers. Overall response rate is 91%. So these are unheard of response rate even for targeted therapies. And the duration of response, if you look at the swimmer's plot, is also very long, good duration of response, bordering on to 2 years. And we now know from the investigators that some of the patients are living more than 3 years, 5 years. And very recently we heard the presentations from Dr. Vivek Subbiah, where he would show a patient who is going on for 5 years, 6 years with excellent quality of life, so on and so forth. And in his presentation, this is a 66-year-old gentleman with poorly differentiated thyroid cancer. Look at the response after 8 weeks. And this is the baseline, and this is after 8 weeks of therapy. Such an impressive response. So this is bordering on to fantastic. And this is other various RET fusion positive other tumors other than the medullary thyroid cancer. And here again, the overall response rate is 50%, and you still see a very impressive waterfall plot. And you also see these various different fusion partners, and across the various different fusion partners which we mentioned earlier, this KIF5B and the CCD6 and NCOA4, these are the common ones. And across these common ones and also some other uncommon fusion partners, the pralsetinib response rate is very good, again with a very good durable response across all these malignancies. And this is another woman with a 51-year-old woman, cholangiocarcinoma. Look at the disease in the baseline, look at the response rate. Fantastic responses after 8 weeks, and very impressive, very quick response rate. And the CA 99 reduces from 100,000 to 1,500. I mean, 100,000 to 82 and 1,500 to 16.4 CA125, CA19.9 in cholangiocarcinomas. So very impressive and very quick response. Safety, Safety response, the major adverse events were all low grade. Usually CTC grade is 1 and 2. These are the most prevalent toxicities, and not very high grade toxicities. Most frequent adverse events were anemia and increased liver enzymes, WBC count, hypertension, and some patients had hyperphosphatemia and neutropenia. And the treatment duration was up to 23 months, and the median relative dose was well tolerated. 96% of the relative dose could be delivered, and there were no patients who needed to discontinue due to adverse events. So this is again denoting that it is a well tolerated drug. Pralsetinib, broad and durable anti-tumor activity, multiple advanced solid tumor types. And with RET fusion thyroid cancers, we see an overall response rate of 91% and 100% disease control rate. And these are literally unheard of. And across other solid tumors, 50% overall response rate and 92% disease control rate in RET fusion positive solid tumors. That includes all these solid tumors, including neuroendocrine tumors. So earlier there were not much therapy available for any of these, particularly neuroendocrine tumor. We didn't have anything. But if we have a RET alteration, then there is really something to go for. The FDA approved in December 2020 pralsetinib for RET altered thyroid cancer. The May 2020 saw selpercatinib, and December 2020 saw pralsetinib getting approved. And in this year, ASCO 2021, the Aero trial update was presented, particularly for pralsetinib use, and it really echoed most of the prior findings. But at the updated presentation, 216 patients and who were RET fusion positive received pralsetinib. Overall response rate of 69% and a disease control rate of 92%. So that is what is the essence of this update, which I would say is quite impressive. And now there are many more targeted drugs that are going to come after selpercatinib and pralsetinib, and you have all these numbered drugs. So we have to wait for the data to mature, and these are exciting times for RET alterations. So with this information, right from 2020, we know that RET has become a very hot topic. And fortunately, as we routinely do a broad-based NGS for most of our solid tumors, we also started to see these alterations. And we have seen it in quite a few patients, but quickly, this is a patient, this is Mr. S. If you can look at this, picture, and this is a lung, and you see that this patient has got a, RET fusion, CCR DC6, and that's the report. And this is a RET fusion, and the CCR CCDC6 RET fusion variant is there. And this is another patient known as Mrs. C, and this patient had this patient is on treatment with us, and this patient also had a right upper lobe lung cancer, metastatic disease, non-small cell lung cancer, prior treated with paclitaxel. In fact, I think 2 lines, and now was found to have progressive disease. You saw the scans, and now the current progression right supraclavicular lymph node shows poorly differentiated carcinoma. That's why the patient was on paclitaxel. And you see that this is the disease on progression with this new biopsy. These are the disease in progression with the new biopsy. We have done an NGS, and the NGS is showing, RET fusion. This is KIF58 RET fusion. So both of these patients we have applied for pralsetinib, and I'm happy to note that both of them have their pralsetinib approved, and we are excited. We are about to receive the first lot of pralsetinib. Probably it's on the way on the courier, probably in a week's time, I'm told. So I'm very, very eager to see how it works out on our patients. Hopefully these patients, our patients, will also show a similar response as was already described by the investigators. So RET has a long story, right, from 1985 to now, and it's really a 25 years journey. But in essence, what has happened is RET is a tissue agnostic targetable biomarker, and probably this is also one of those rare indications where tissue agnostics approval, like we have already seen tissue agnostic approval for drugs, but now RET has added to that kind of portfolio. You see that RET was first identified in 1985, and then it was structured, and finally now, we started to decipher the RET. Vandatinib and cabozantinib were 2011 and 2013, and after 2015 came the Loxo 292, which is selpercatinib, and Blue 667, which is pralsetinib, and the FDA has in fact approved both of that in 2020. So I think these are emerging opportunities, and these are patients in whom there were no good options before. So we are happy to see that some very, very useful options are emerging, and hopefully these drugs will be very soon available to Indian patients also. I am very aware that several of our colleagues across the country have already been able to put few patients on this. So we are also looking forward to that experience. But with these drugs, with these options, and by detecting RET mutations and RET fusion, particularly with the broad-based NGS, and offering the right treatment to these patients, I think we can try and beat this cancer in a substantial manner. With that, I really thank you for your attention, and I thank the 4-Base Care for putting us all together and for this wonderful opportunity to talk to you. Thank you so much.
Thank you very much, sir, for this exciting session. And it was a lot of learning from a clinician to know firsthand how often do you see. So the moment we started using a broad-based NGS, I think we start becoming a lot of new, all kinds of cancer types. It's just not lung. I think there is going to be a good benefit for all the patients who are RET positive in Indian cancer in context, I would say. So right now, I guess there is one question between RET mutations and NTRK mutation-based drugs. What has been your experience in treatment of cholangiocarcinoma? Sir, you are muted, sir.
I must, I know, first of all, I must admit that I am looking forward to the experience with these drugs. And as I've just told that in our RET mutation, or sorry, RET altered patients, in 2 patients of non-small cell lung cancer, we have applied for pralsetinib. And that is because, right now nobody can buy this drug, afford this drug, and you have to go through the approval process. And when you go through the approval process, you also need the test result, and then you need a cooperative, company to support you, so on and so forth. And there must be some background help to reach out to those. So that's how it actually works out. And so we have pralsetinib approved for our patients, RET altered patients in non-small cell lung cancer. With regard to cholangiocarcinomas, I have not yet seen RET alteration in a cholangiocarcinoma, but we have seen, several other difficult alterations in cholangiocarcinomas, including HER2 to KRAS to whatever. But yes, NTRK also. But again, at this point in time, my very straightforward answer is I am yet to treat these patients with these drugs. I'm eagerly waiting to put my hand on these drugs.
So what is your experience on the frequency of NTRK mutations in India?
Top of my head, again, I would think that probably around 1 to 2%. That's what I think. So, but yeah, that's what I think. Again, another mutation that is across the different malignancies. So all these are very important, because these mutations are now, actually now we see that most of these changes, most of the genetic mutations seem to be across the tissue. They are really tissue agnostic, except very special, very few, which are really what you call that. It is very unique to a certain tissue type. One example is EGFR for lung, which you may, if you dig harder, maybe. But then if you talk about ALK in lung, ALK suddenly can appear somewhere else in some other tube. So this one is these are mutations that is across the board, different malignancies.
Sir, even in the ALK case, in anaplastic large cell lymphoma, we do see the ALK fusions, right?
Right.
But we do not hear much about the generation of drugs, mechanism of resistance, and is it because we do not have that much learning to call ALK as a not a pan cancer, but then ALK being part of multiple tumor types to go in?
That's an interesting question, and actually it's a difficult question. I'll say why it is interesting, why it's difficult. Because what you have touched upon is that why ALK is seen in lymphomas, and ALK can be seen in lymphomas, and ALK can be seen in some other entities, like totally unrelated malignancies can have ALK. Now the problem is, why is it not uniformly effective as it is effective in the lung? This phenomenon is already seen. For example, it is well known that the BRAF, which is a very common thing, when you treat with BRAF therapeutics, the response is different for melanoma, and then comes the lung, and then if you see the BRAF in the colon, so if you see, the response is not uniform, and therefore you see the approval also is not necessarily on first line for all tumors, and then you will see in some tumors that you can go with conventional treatment and the indications are on second line, third line, because the responses are not uniform in all these different malignancy types. But on the other hand, certain malignancies, so certain mutations or changes like RET and NTRK somehow seems to be cutting across tissue types, and you see that if it works in non-small cell lung cancer, it works in cholangio, as somebody is interested, and it works in medullary thyroid cancer. So it works with a very high sensitivity and specificity and a very high response rate across many malignancies. So that's very special about some of these changes like RET and NTRK. So these are two specialities. But some other mutations or changes which we mentioned. If you see ALK and if you see BRAF, and you don't see a uniform response across all different medicines. So that this phenomenon is already understood, and this phenomenon is already addressed by very eminent physician oncologists. You will see this to be spoken by Dr. Razel Korzarov and all those people. But there is no, they all know the data, but I don't think there is a clear explanation. Maybe there is a deep molecular explanation as to why it works so well in melanoma and doesn't work well in some other. So that is, I think, a really deep domain into the molecular genomics of it.
And then the ease with which probably the tumor cell is trying to take the drug in. Essentially, the drug should penetrate through the tumor and enter inside the tumor cell. Probably the penetration rate is somewhere these the shuttles which are there, the membrane proteins which take these drugs inside, the kinase inhibitors. We do not know. Probably that's where the medicine should come hand in hand with the lab to see where we can work together. Maybe a combination therapy will make effective, sir.
That's possibly. See, once you then you are going to you are opening another topic of discussion, wherein whether you can call this as inherent resistant pathways, where there are complex mutations, or you want to call it as a clonal evolution. I think we are theoretically going into that domain, and therefore whether a combo can be effective to shut down the escape mechanism. So those are different discussions. Those are really, really, molecular tumor board discussion kind of thing. And there is no single answer to that. One more question that has come in the chat boxes. They want to ask whether between the two, pralsetinib or selpercatinib, which one is more efficacious? That's the question. RET altered solid cancers. I mean, again, as I told you, I do not yet have the access, but we are going to get pralsetinib for our patients, two of them very soon. And because we found the pralsetinib application process to be a little comfy, we did that. And I don't know whether we have anything to choose between the two. I don't think it's an expert answer. But if you look at the data, particularly the data presented in ASCO 2020 by Dr. Vivek Subbiah, pralsetinib seems to be very impressive, at least definitely in thyroid cancers and in lung cancer. That's my take on what I have learned so far. And another question is that with increasing number of tumor agnostic markers being approved, what is your opinion on tumor agnostic markers replacing the conventional site-specific therapies in precision oncology? Again, this is a fantastic, deep question. This is our dream that very soon we will be just doing a test, and that too even probably a liquid biopsy, and get a tissue agnostic marker, and then put the patient on that particular drug, whether the patient has got a colon cancer or a lung cancer or a breast cancer, and the drug works everywhere. That's actually still a dream. That's still an utopian dream. But the RET drugs and NTRK drugs are probably close to that particular, claiming that particular spot. But very soon, a lot of things are evolving. So hopefully, your question will be, the delegate who has asked this question, probably very soon, maybe this is looking into the future. And which one is more efficacious?
You already answered.
Again, the same question.
Yeah.
And
the drug response rate.
Yeah, different tissue types. Yes, that is already shown.
Yes.
For example, for MTC, it's very, very high. And for the other varieties of thyroid cancer, it is next high. And then comes the non-small cell lung cancers. And then the other tissue types probably come down the line. But that is as per the current data. But if more experience is gained, we will be knowing. And somebody wants to know whether CA pancreas with pralsetinib prognosis. So probably we are looking at an advanced setting where all the first line and second line drugs are already done, and the patient with advanced pancreas has a RET alteration. And at this point, I mean, definitely these are advanced diseases with poor prognosis. But just 6 months ago, we had nothing that can be offered, to a situation where there is something meaningful that can be offered for all these patients.
So there is one question. In the trial, both the trials, there were patients in pan cancers where the corresponding partner to the RET, there were some unknown partners, novel partners. So do you think we are ready to treat, like in the trial, it was okay to treat patients because they would have come with a consent, and most of them were prior treated, and different kind of patients did not have an option, so they went into the trial. Probably all the lines of therapy failed. So what is your take on this, sir? If you get an unknown gene partner other than KIF5B or CCDC6 or NCOA4, would you still?
Yeah, fortunately, if you look at the data set, both pralsetinib and selpercatinib, what you see is that they have been effective across the various fusion partners. That's what we see. But then again, the question is whether they are more effective against certain fusion partners versus the other. That's why I tried to, anticipating this particular question and this particular discussion domain, I had shown the the gene and the exons and the RET protein itself. So we know that RET protein means it doesn't mean a single thing. It's on the membrane something, below the membrane something, and above the membrane something. Obviously, if there are changes in any of these different sites, it would mean that it's generally well known that if we have an alteration above the cell membrane, then it's a general wisdom that certain antibodies will work there, and if it is below the cell membrane, the wisdom is that TKIs work well. That's a common wisdom. So that is a very common wisdom. It's just like A and B, but then it looks like there is something called A1, A2, A3, A4 above the membrane, and then there is B1, B2. So the short answer is that as of now, the data is that it's across the fusion partners. So I think we are justified. But like the EGFR story, a few years ago, people wouldn't accept when we say that exon 19 is different from exon 21 or exon 20 insertion, and L858R is different. If we say that there were opposition, no, you can't. So that was exactly 3 years ago. Now everyone agrees that. So it looks like there are two. So soon, over a period of time, we may, as more and more drugs emerge, we may be able to say that certain fusion partners are going to respond much better, and certain drugs may work specifically against certain. But that's again into the future. At this point, use the drug across all fusion partners.
EGFR drugs, are they effective in RET mutated cancers? How it is different from EGFR mutation resistance? Can we address in similar lines a RET mutation resistance? How effective
that is another very deep question. Thank you, thank you, Dr. Prabhakar Tiwari, for asking that question. Dr. Abhijit has asked the CA pancreas with pralsetinib. Dr. Prabhakar has asked this EGFR question. We know that there are various EGFR resistant mechanism emergence. We know that MET exon 14 skipping mutation can be one of the resistant mechanism, and similarly RET alterations are also found to be an resistance mechanism in EGFR treated drug. There is a particular patient data set that I have seen. I have it in my, I can also show, in which the patient who was treated with let us say earlier the patient had only the EGFR change, then goes on to receive osimertinib, then begins to have the change, then ALK appears, and finally RET RET alteration appears, and at that point the investigators have tried to combine the EGFR drugs along with the RET RET specific drugs. There are such data set you can, or at least there are such patient reports, so one can go back and see those reports and see whether we can judiciously combine an EGFR therapeutic drug along with RET anti-RET therapy. I think that is possible. That's what I think. But that is based on some patient reports that I have seen. The other question Prabhakar asked is combination of immunotherapy. I think that's a very open question. Fortunately, immunotherapy works in a completely different mechanism. So maybe you can add it, and maybe you can improve but again, that's a very general question and a general answer. But the more we speak about this, we are now getting into more and more data-free zone, they say. That is, you are on your own. There is no data to fall back. You are on data-free zone. So you make your own decisions. That's how these are addressed. Then, sir, how the frequency of RET alterations vary from different ethnicities? Is there any data available to support? My answer is I really do not know. I don't know. Maybe I can go back and look at the data set of both pralsetinib and selpercatinib, whatever we have, and I can see whether ethnicity is one of the subset or not, but not that I'm aware of. And does data indicate that the RET inhibitors show better response than ALK inhibitors in non-small cell lung cancer? ALK inhibitors are already on the pole position. We know that. See, ALK inhibitors, we know that, unlike EGFR, ALK inhibitors are very highly efficacious, and ALK inhibitors are known to have a long duration of response. Everybody knows that. When you speak about ALK inhibition, you talk about 4 to 5 years of life in a patient with ALK alteration. So they are very special. They are already high scoring batsmen. So now you want to compare RET with ALK. There is no need to do. RET is another high scoring batsman. It is just like trying to say that, between the two batsmen, who is better kind of thing. So at this point in time, it's lucky to have all of these. Again, RET is also a very high ORR and also very high specificity. So RET inhibitors, probably when you classify the high scorers, RET will come close to ALK.
Only thing is, right now we do not know the mechanism of resistance. Right, sir?
Yeah, that is again, I don't know how these are early days. Eventually the data will mature, and probably by next year we'll start talking about
Yes.
resistance. But why do we want to know about resistance? Particularly when we see that in patients, we see some score like disease control rate of 100% and an ORR rate of 70, 80, and 90%, and a DOR of, duration of response of, duration of responses, the median is not reached. That's what you repeatedly see in and the PFS, some of us has not reached. So what does it show? These are long marathon runners. So then resistance is still not a major issue.
But in the ALK, we have got several second and third generation drugs. No, sir?
That is because, ALK, the anti-ALK drugs, they came 10 years ago. So you kind of sort it out and then eventually learn more and more. So
great. Next.
Oh, definitely. The tumor is not going to sit quiet. Just because we detected RET, it's not going to sit quiet. It's going to find a way out of RET. It will do. So we will learn.
I think most of the questions have been answered, sir. All the questions have been answered. If there are no more questions, I would like to thank you, sir, once again for this interesting session. And we have attendees from several places across the world. Philippines, Sri Lanka, several countries. They are very eager to listen to you because of your experience in precision oncology, precision medicine. You're one of your thought leaders. So thank you so much for this interesting session and sharing your experience in treating these patients. We look forward to have more and more sessions with you on experience from different biomarkers, sir.
Thank you so much, Dr. Vidya, and thank you for inviting me and all those kind words. And thank you so much for the organizers and Forbase Care for putting us all together. It was my pleasure and a great opportunity for me to be with you all.